This is a case of APC injury, which is slightly different from the routine ones. I'll just present the case and then we will have the discussions which we can have later. He's a 32-year-old male who was hit by a vehicle, had some abdominal injuries as well, which were treated conservatively, and had pain in pelvis. And this you can see is the MLC X-ray, which is normally got. So this was the X-ray which we had got. And as per the protocol, once the patient was revived and was resuscitated as per ATLS, then the pelvis X-rays were done. So these are his pelvis X-rays. And you can see, and if we just look at them and try to find out what exactly is there, we can see that there is some symphyseal disruption as well as a left SI joint dislocation, which we can see by the opening of the SI joint on one side and the symphysis which has opened up anteriorly, which is around about 2 centimeters to 2.5 centimeters. We all know if we are going to have the pelvis fractures or so, we will get the CT scans done. So this is what the CT scans were done for. And this is the standard thing which we could get from the 2D and the 3D scans. If you look at it, all the scans, both the coronal as well as the axial scans are showing you the SI joint disruption. And the anterior SI joint and symphysis also can be seen in the 3-dimensional CT scan VRT images. So if we have to make a diagnosis of a pelvis injury, this will come into most likely, I think, APC 2 or 3 injury based on the wide displacement of the SI joint, both in the axial section as well as the coronal, which appears to be both in the anterior SI joint ligaments as well as the posterior sacroiliac ligaments. What is the management? Management usually will be a symphyseal disruption. So we do a symphyseal plate, and based on our preferences, we can put in a iliosacral screw, a transsacral, transiliac screws, or a usual anterior SI joint plating, which are the most common of the methodologies or options which we use for an APC 2 or a 3 injury. So if I can say, if it was so simple, it wouldn't have been here. So what is different here? So if we can see, this is the index case outlet view, which I am showing here. This is another case of a pelvis fracture. And this is another case of a pelvis injury. But if you see the sacrum in all the three, you can see the sacrum is slightly recessed in the pelvis in the normal one. Here you can see that the L5 and the sacral ala have got a transitional sort of union. And if we see here, there is some oblique association between or you can say lumbralization of the sacrum or the sacralization of the lumbar vertebra. So these ones are the normal. This one I would say is a transitional fracture or vertebra, whereas the index case which we are discussing is having sacral dysmorphism. So if we look properly at the outlet view, these are the classifications or the characteristics of a sacral dysplasia, which is an upper segment sacral dysplasia, which is that the sacrum appears to be higher than the ilium. The mammillary bodies which are there in the lumbar vertebra can also be seen, which is seen on the right upper corner of the arrow. The sacral foramina which we see of the S1 are oval in an outlet view rather than roundish, which we all want that it should be a perfect circle. We can also see a residual disc space between the S1 and S2. And if we look carefully at the SI joint and the sacral ala, we can see that the angle of the sacral alas are acute alar slope is there. So these are the characteristics which we should always look for in a sacral dysmorphism. And this is a paper by Chip Rout and Sam Morshed, where they have said that these are the characteristic features which we can see in the sacral dysmorphism. Is it so common in India? Yes, this is our own paper in JCOT, where we found that yes, there is sacral dysmorphism in India. And in one of the subsequent papers, there were 300 pelvises, and we found roughly 60% had some sort of sacral dysmorphism. I'll just like you to have a look into this CT scan. It shows where exactly all the views are here. And if you can see, concentrate on the lower sagittal section, and you can see the two red and blue lines, which show where exactly our entry point for the iliosacral screw is and which is the angulation which we are looking. I'm looking at perfectly sacral views. I've angulated it. And you can see what is in the coronal section as well as in the axial sections, which we can see that the angular and the alar slope is quite different. The slopes are different. In a normal CT scan, if we look, these are the ways where we can put in the screws. But this is the index case, which is dysmorphic. So if you need to put in the screw in the S1, you have to be very cautious, not like the regular one. And if you look at the coronal image as well, if you're putting in a screw, you have to be very accurate to be going above the foramina and below the sacral alar. However, if you look, the S2 vertebra and the space between that is hugely prominent. And that's what is all about. So this is the 3D scan of our index case. These are the alar slopes, and you can see the neural foramina is very high, as well as you can see that the S2 corridor is very big of our axial scans. So what we did, it was a supine. We took it fixed X-ray, fixed symphysis first, like the standard ones. We had the symphysial fixation done with 3 screws on the either side, and we had accurate reduction of the anterior symphysis. And we had planned for an iliosacral screw fixation, which we planned that we will be putting it for the S1 in an oblique fashion. The posterior fixation, you can see we have taken the ICDs, and below that, I'm taking it very low on the lower level and the lower posterior quadrant of our rectangle. And if we look at the outlet view, the direction is acute alar slope is taken into account in the outlet view out here. And subsequently, the screw has been put, which needs to compress it. Once we have put that, then we go in for the S2 corridor, where the S2 foramina and the vestibule or the corridor is huge and wide, which we had seen on the CT scans. And then the screw as a neutralizing and a compression is put in the S2, which gives us a transsacral or a transiliac long screw, which gives us a good reduction and a good stable fixation of the posterior side in this. This is the long transsacral screw at S2, and this is the anterior screw, which you can see in S1 with a lateral view showing that our screw of the S1 has to go at an oblique angle to the alar promontory. This is the post-op image, both iliac outlet and the normal images. And you can see that as we go, the stability of that fixation has been good. And we have been able to get and maintain that fixation for 3 months and 12 months when he has been able to do all his activities. So I'll just finish off this case presentation by saying that sacral dysmorphism is a thing which may be required to be looked at. It's a common entity. You require the CT, which we say has to be a must for all the cases. This is why the CT is important, because your iliosacral screw might go in a wrong direction and cause neurovascular damages if you do not see the sacral dysplasias. As I said, there are wide implications for surgical management. And if you need for this, remember that if you look for sacral dysmorphism, you will have a narrow and angulated alar slope of S1, but a very wide corridor of S2 where you can put in these screws. I thank you for your hearing and for giving me this opportunity.